Good afternoon, everybody, and thank you for being here. My name is Miguel Cobas. I'm a professor of anesthesiology and surgery at the University of Miami. And I'm also the president of the Society of Critical Care Anesthesiologists. I would like to share my screen so we can all see the presentation. And I have titled my lecture, Why I Do What I Do, since this is a lecture for medical students that are interested in the specialty of anesthesia, and I'm going to talk about a little bit about critical care. Thank you very much to the Foundation for Anesthesia Education and Research and the opportunity to be able to share these moments with you. So this is a little bit of why I do what I do. Many years ago, someone was shot in the face. I was doing my first year out of medical school, and I was doing a little bit of an internship in Venezuela, where I went to medical school and where I'm from. The entrance of the gunshot wound was just anterior to one ear and out anterior to the other, like a straight line. The patient was completely alert and awake, lucid, and he was telling us that he was slowly choking. And we can tell why, because there was this enormous clot that was becoming formed in the back of the throat that was basically obstructing his airway. The patient collapsed in front of me, grabbing his neck, and he couldn't breathe anymore. And the only other doctor that was there that night, every night actually, is the anesthesiologist on call. And later I learned that the anesthesiologists, they always left it on call because they decided, the hospital decided, that is the person that can keep somebody alive. And that was very prescient and very real. So what happened next? The anesthesiologist and me, we took the patient to the OR, and without knowing, I learned the concept of apneic oxygenation and a little bit of fiber optic intubation. By putting a pediatric fiber optic, the doctor was able to pass a very small tube, just past the clot without disrupting it, because otherwise that would have been a massive bleed, and was able to insufflate enough oxygen into the patient's lung, waiting for the time that a surgeon that was on call would show up there in about 20 to 30 minutes and eventually complete a tracheostomy where the patient had a definite airway. But this was one of the most terrifying moments that I have ever lived at that time. And I still, 20-something years after it happened, I still remember vividly, due to the nature, the gravity of the situation in front of me. So what are the things I learned that night? There were a few things. First, even if you don't know what you're doing, or even if you believe that the situation is more overwhelming than what you can handle, is hang around. An extra pair of hands is always important. Don't be intrusive, but be helpful. Don't underestimate anyone from your team. The fact that other people have less training, different training, or a different degree than what you have doesn't take anything away, and actually they will help you, and they'll be better at a few things than what you have been trained to do. Have a backup plan. As I was looking at all that was happening in front of my eyes about how can we get some oxygen into this patient's lungs, I knew that the anesthesiologist was telling me also everything that he planned to do afterwards in case that didn't work out. And I thought that was pretty neat, because you had to do that under a tremendous amount of pressure and with minimal time. The care of the patient doesn't finish in the OR. And this is an important transition between an operating room and the critical care unit. We took the patient to the critical care unit, and then afterwards we had to decide what to do in terms of what mode of ventilation we were going to use, what type of sedation we were going to use, whether the patient needed antibiotics or not, nutrition, and so forth. The right answer sometimes takes time. It's very hard sometimes just to develop a plan from the get-go all the way to the end. You have to be flexible and adapt to what the things that are coming to you. And finally, develop and learn to trust your instinct. And the only way to develop and trust your instinct is by doing it many times and be presented with many different situations at different times with different patients. That's how you develop an instinct, and you need to develop that. So after all this, and after seeing this patient practically die in front of my eyes and somehow being revived and had an emergency tracheostomy and bleeding and all that in, you know, in a matter of half an hour or so, I thought that anesthesia and critical care were very, very cool. And that was one of the reasons that I decided to go into the specialty. But if you look back, anesthesia and critical care have been very cool for a long time. Actually, if you trace back the what we tend to think that are the origins of critical care in the 1950s, it usually related to the epidemic of polio. And patients that were affected by polio had aplastic paralysis. They couldn't breathe on their own. And what was the typical treatment at that time was to put them in a kind of an air chamber that had negative pressure. It was like imagine like a plunger that is taking, that moves the chest wall out. And instead of the way that we do it now, which is, you know, a tube that puts the air in. So this machine that was called the iron lung is a negative pressure ventilator. It basically what it does is allows the chest wall to the entry of air. But the problem with that is that you can imagine that that is not very efficient in terms of getting a good tidal volume inside your lungs. And a lot of the patients died because of atelectasis and because of secretions and because of pneumonia. In this particular case, Dr. Born Ibsen, who was an anesthesiologist in Denmark, was brought in and say, hey, can we do something about this? And then he realized that by maybe just doing something that he does for the operating room, which is to placing a tube, a breathing tube down the patient's trachea, then you can provide oxygen and provide air, ventilation in a much more forceful way than just by doing the iron lung way. And therefore, these patients were able to be suctioned, and these patients were able to be treated appropriately and with less atelectasis and less collapse. And these patients did, with this technique, the patients did much, much better. And that is another strength of being a critical care anesthesiologist, which is the fact that you are interacting all the time with different specialties, multidisciplinary in nature, and always trying to figure out what is the best way to come together for the outcome of the patient. But we have continued to be very cool. And I wanted to show you the picture of this gentleman. His name is Richard Harris. And Richard Harris is very famous because he is an expert diver, but he's also an anesthesiologist from Australia. And Richard Harris is the doctor that came up with the idea of how to rescue the soccer team that was in Thailand, not about 2 years ago. This is a soccer team, if you probably remember, that went into a cave, and the entrance to the cave and all the conduits to the cave were flooded, and there was no way for them to come out. And at one point, there was a good possibility that all these youngsters, there were, I think, about 15 of them plus a coach, were going to die there because there was no way that there was going to be a team to rescue them over there. So this gentleman decided to put together the two things that he does best, diving and anesthesia. And he figured out a way to say, well, what about if we anesthetize these kids? These kids didn't know, most of them didn't know how to swim, let alone how to scuba dive. What about if we anesthetize all these kids and we go there one at a time? There's a diver that will give them a shot of ketamine and a shot of atropine, as you see there in the caption. The ketamine will anesthetize them and will put them in a dissociative state, which is basically you're unconscious but breathing on your own and still may be able to follow minimal commands. And then atropine to dry the secretion, so the patients do not produce a lot of saliva or other secretions that may compromise their breathing. And so they went like that, and they went one by one, and they extracted every single one of the members of that soccer team very, very successfully, due to the incredible effort and of Dr. Richard Harris. He was named Australian of the Year in 2018. And that gives you a very good dimension of what anesthesiologists and intensivists can do, is completely think outside the box, show up where least expected, and come up with a solution that was completely innovative, at the same time extremely safe for these kids. And of course, we need to talk about the pandemic, I'm going to bring, I brought you this, just this front page from ABC News that says that anesthesiologists hailed as special heroes in a fight against coronavirus. And this article, it talks about how skillful we are at intubation and how dangerous the procedure is, but because of our high level of expertise and skills, we're very sought after. We're the heroes in the fight with the coronavirus. But I think the article lacks the fact that after we intubate the patients, anesthesiologists continue to care of these patients, and there are many ICUs and many patients with COVID-19 that depend on anesthesiologists to survive and be treated appropriately. Anesthesiologists not only intubate, they know how to manage the ventilator, they know how to keep them sedated, they know when to take the tube out, and they know how to manage the hemodynamics and the hematologic complications that these patients are presenting. So it is true, I'm not going to say that we're not heroes in the fight against coronavirus, but I think we're also, not only because we intubate people, but because of the comprehensive care that we provide to these patients. So just a few numbers and a few statistics. More than 5 million patients are admitted annually to the US ICUs. The reasons are there: respiratory insufficiency, a need for a ventilator, myocardial infarction, either stroke or intracranial hemorrhage, PCI, status post cardiac cath, or sepsis, whether you need mechanical ventilation or not. There is a need for intensivists, and there is a, as you see, there's a growth in intensivists, which is remarkable, but still not enough. Over in 2008, about 2,000 fellows, and 10 years, about 1,000 fellows more. But still, there's going to be a need for more intensive care doctors, because we're taking care of older patients, sicker patients, and we have better technology. So at its broadest definition, what we do is a all-encompassing specialty with almost limitless boundaries. Critical care involves the use of life-sustaining, high-technology medicine, catering to a patient population that extend to both extremes of age. And it is important also to know that as critical care specialists, we have to be compassionate, and we have to be involved with the end-of-life care as well. There's so many opportunities to grow in our field, and obviously I'm going to lean towards anesthesia because that's my mother's specialty, if you will. But there are also internal medicine, surgery, and emergency medicine. But if you ask me, anesthesia is the best one to get into critical care, and I'll tell you why. We're comfortable with technology. We're comfortable with machinery. The first month that you're going to be in the OR, you're going to become familiar with an anesthesia machine, which nobody else in the hospital knows what you're doing with that thing. They have not even a clue where to turn it on. And we're, as I showed, good with unconventional thinking. We're used to proactive planning and crisis management. Patients who are hypoxic do not last. We need to figure solutions quickly, and anesthesiologists are the principal specialty that does that. There's a lot of diseases that are taken care of in the ICUs that their treatment is then propagated to other areas of medicine. For instance, ARDS, everybody knows about ARDS and sepsis. Many of the principles how to treat these diseases come from studies born in the ICU. Low tidal volume, the type of food resuscitation for certain types of injury, glycemic control. All those are studies that were initially in the ICU, and now we talk about them almost for every patient. Despite all this, 80% of all units in the United States are managed by doctors from internal medicine. And I think that's a shame. We in the United States, as opposed to other parts of the world, like maybe in Europe, we're not known, we're not seen as the ICU leaders. And that is something that with this talk and with many other things that we can do, I hope that in the future we can change. If you look at the data, less than 10% of the United States ICUs are led by an anesthesiologist. However, there are some encouraging signs, as the fact that every year we have a relative increase in the fellowship spots, as well as residents and fellows graduating from our programs. It is important to develop research, like I mentioned before. Large, high-quality trials that give incredible and solid answers to many of the questions that we ask in clinical medicine every day. And as medical student, I think it's key that there should be early participation in ICU rotations. That way you get familiar with the ICU patient, we get familiar with the ICU team, and what is it to work in a completely different environment than the operating room, yet similar in terms of intensity and reward. Get involved. There are excellent organizations that will hold your interest and will provide you with a large amount of material for those of you interested in critical care. The American Society of Anesthesiologists, obviously, the Society of Critical Care Anesthesiologists, and the Society of Critical Care Medicine are three of those organizations that provide excellent resources. And for residents, the cost of, for medical students and residents, the cost of joining these societies is nominal or even free. So these are opportunities that you should have now. And I think with this slide, I'm gonna conclude my presentation. If you look, the picture on top is an ICU patient, believe it or not, is behind all this machinery and all this high technology. There is an ECMO pump, there's a balloon pump. You can barely tell that there's a human being in there, but a human being is in there and is well taken care of because of everything that we're doing and all the technology and all the human care that we can apply. So with this, I'm gonna finish. If you have any questions, I'll be glad to answer at the end, and we have, I think, a question and answer. Thanks very much, and thanks to the foundation again for the invitation.